Welcome to episode number 34 of Future Proof Physical Therapy. I have here my partner in crime, Dana, and today we are grateful to have Ben Barron as our guest. Ben has been part of physical therapy and rehab industry for a while and has been in health technology for a pretty long time too. So you can say one of the pioneers in integration and use. So with that in mind, I will hand off the mic.
Well, sure. Thanks. First of all, thanks, Alex. Thanks, Dana, for having me. I don't say this lightly, but I do listen to the podcast. I have it automatically downloaded when they come out. So I appreciate what you guys are doing and pretty honored to be here. Yeah, so my name is Ben Barron. I am a physical therapist. I'm a proud Boston University alum who lives just north of Boston now in southern Maine. So my career, I think it's kind of funny. I went to physical therapy school in order to be a pediatric physical therapist. And some things happen along the way and you end up in different places. And I ended up being one of the owners of a 23 clinic private orthopedic practice in Greater Boston that we sold to a private equity-backed strategic, and where I stuck around and I worked there for a bit. One of the interesting things that kind of happened along the way is we had actually built a revenue cycle management company where we helped other private practices around the country doing their billing and collection. Probably had 50, 60 clients. And part of that actually had become a strategic partner of one of the larger EMR companies in the space who would send us business that they weren't able to help because it was perhaps maybe a little bit more niche. And so when I was looking to make a transition in my career, I hadn't even considered moving into the world of technology, but actually got a phone call from this partner who bringing in someone who had relationships, understood the industry, and that was about almost 10 years ago now. And so since that time, I've been in a couple different technology spaces, typically on the growth, revenue, sales side of things. But really, I just look at the way I got here, frankly, was a story of scale, is that I am passionate about the industry of PT and the impact that we have on people's lives in every setting that we work in. And when I was a staff PT, I could have that on the 8, 10, 12 patients that I saw that day. When I ran a clinic, I could do that for 3 or 4 therapists. When I owned the business, we had 100 therapists at one point that I had the impact. And now I feel like I'm in the role where I can really take a step back and try to figure out how can we help thousands of clinics, tens of thousands of therapists, and enable them with potentially tools that help them do a better, easier, more efficient, So that's kind of my story in a nutshell.
You have been impactful. So I think based on your road of discovery in physical therapy, right, and based on the trajectory and building a system, building revenue cycle management apart, and this is off grid and feel free to deflect it. But do you think we are enabling therapists to do a hard job better, but are we doing a good job making the therapist's job easier? Or are we just supporting their hard job by enabling them to do it well?
I think that's a really, really good question, Alex. And I one thing that I want to call out for a second in my own disclaimers is that, I am an executive at Net Health, which is, we have EMRs in the SNF and assisted living space called Optima. We have Redoc in the hospital world, and we also have Limber in the digital MSK world. And so I do have a dog in this fight because I do feel as if enabling these therapists with technologies to make them lives a little bit easier is, one, it's my day job, but also it's something that I believe strongly in. So I just want to call that out. So it's not there's no false pretenses here. Alex, I think about it is we are incrementally making an imperfect system less imperfect by giving people new tools and new shiny objects. And we are doing that without maybe fixing core issues. I can completely see that. I think the other side of that coin, though, is that it's a really difficult place to be where we can't necessarily be the ones that fix the macro issues. Meaning, the three of us are not going to be able to change the fact that the vast majority of physical therapy in this country happens in a fee-for-service model. And a fee-for-service model incentivizes certain behaviors that may or may not be related to the most efficient, effective, productive way for therapists to spend their time. But it's the reality that we live in, and therefore we do have to optimize for that in some ways. And so I think that we have to realize the world that we live in today in order to be able to pay our bills, while at the same time keeping one eye to the future and 3, 5, 7 years out and trying to figure out how can we get, even if it's just incrementally closer day after day, understanding that we're not going to be the ones ultimately that necessarily decide the future of healthcare in this country and how it's administered or paid for.
Yeah, and it supports the statement that it's slow progress, right? Slow step progress. So there's not going to be a paradigm shift and a exponential growth that happens in a span of a decade. Again, we're not going to be. There's not a single entity or an individual that has the capacity to be the agent of change. But the closest proxy to that is if you're carrying a 200-pound boulder on your shoulders. And I think a lot of times, instead of reducing the weight of the boulder, we're creating extra shoulder pads so it doesn't chafe the skin as much. That is that visual, right? Like that we're good at like creating pads on the shoulders. Maybe we can give them advice to squat a little bit, so lift with your knees, but we're not taking the boulder off because we are living in a fee-for-service model.
And point very well taken. I think that's a lot of the sentiment, right, that we hear from therapists is some of it is skepticism about how things are going to change. Some of it is not seeing opportunity that's right there in front of us to improve how we can do financially in fee for service, like prioritizing access and evaluations. One of the things we're trying to bring a little bit of light to, and it's value-based care. Most therapists really live in a silo. They're not seeing how much it's happening. And we are in now a time where an innovation center team that is really leading health policy at, alongside CMS. They have a very strong voice and leadership is backing them. And they are doubling down on the value of primary care and behavioral health and shifting fee schedule dollars towards their RVUs and away from specialists, which has been a pattern. It's bipartisan support. But now we're seeing, models that have the ability to disrupt us or be opportunities for us to look at our role in the health system differently, but where we're going to have to lead. We can't expect that advanced primary care groups are going to reach out to us. We're going to need to do that. So I wonder when we say we're not going to be the ones to lead it. I agree. We're not leading it. But where might we be missing the boat because we don't see what's happening around us and we're not linking it to our own risks and opportunities, starting really simply with behavioral health up 19. It's really about the weighting of our codes and what we can do. So what risks are there right now that maybe do you think we should be paying attention to or that you hear, or what things may be overblown?
I think that if we were to start not with a crystal ball on policy, but on a little less cloudy crystal ball in terms of macroeconomic and population trends that are a little bit easier for us all to agree upon. I think there are some things that if I were still an owner of a private practice or even just part of a physical therapy outpatient practice in general, that I would be paying attention to.
Mm-hmm.
The first is, as many people know, that the APTA released in the PT Journal this year their workforce study, which showed that we are in 22. It's probably further along now, but in 2022, we as a profession had 12,000 fewer therapists than the market demanded. That's just a data point. We are also not going to catch up with the number as is till as far out as they looked, which is 2037. So it's probably beyond that, but at some point you got to stop looking into the future. And so what that tells me is that the labor insert noun here, crisis, shortage, whatever you want to call it, is the new reality. It's not going anywhere else. And then the next is the population side of things. We all know that the population is aging. We also know that physical therapy is very well recognized as being a conservative care model that creates, hypothetically, fewer downstream costs for the healthcare system, creates good results, especially when used appropriately for the right diagnosis in the right way. Alex is amazing at getting a lot of this research out there in order to show exactly where can we plug in the best and have the most economic impact, frankly, as a profession. And so I put those two things together and I see we're probably going to grow. We're going to outgrow the general healthcare market as a physical therapist over the next 10, 15 years with 12,000 fewer therapists today. That's not going to get fixed during that time. And so that, to me, that screams we have to come up with innovative care paths that allow us to increase our capacity to get patients through our doors that do not rely upon the throughput models that we had historically, which require me as a therapist and a patient in a room for 40 minutes by themselves in order to heal. And because we cannot meet the needs of the community and of society if we do that. And I think value-based care links into that, because then we start talking about how can we manage a larger panel of lives and how can we have greater impact in our communities. But to me, it comes back to things that you can't argue about. There aren't enough physical therapists and there are too many people that want PT. And that trend's not going anywhere. So if I'm a really innovative physical therapy practice owner or executive or anything else, that's the problem that I'm looking at now and trying to figure out how do I optimize for that while I understand the fact that
I think that's profoundly said and a very well articulated way of where we are and where we need to go. So let's get the ball rolling then with some of the pre-prepared questions. And one of them is about RTM systems. So specifically, CMS made it easier to build RTM systems. And so first, can you go over some of the changes to the schedule that have been proposed and have occurred? And can you expand on it to what RTM system actually does to a traditional legacy system?
Sure. So a lot of this answer is obviously a little bit different than it was, as we sit here on July 31st, 2 weeks ago. If you asked this question, we're in a little bit of a different place. So I think it actually bears going back to 2022 in order to answer it. So January 1st of 22 is when RTM codes were approved by CMS, made it into the physician fee schedule. And it was the first time in my 20 years as a therapist that there is a new way for us to provide treatment and be reimbursed for it in CPT codes. That was the first time that had happened. Really exciting, positive, also new, different, and, takes a lot of adjusting to get through that process. Then we fast forward to January 1st of 2026, when the 26 fee schedule came out and the final rule came out. The codes were actually expanded. So for those people that aren't aware, the codes are essentially, this is an oversimplification, I can provide some fact, but they're broken into essentially 3 buckets. Are we providing instructions and setup on a FDA-approved device that allows us to do remote therapeutic monitoring? That's kind of one bucket of code. Secondary codes are, is data transmission happening back and forth to an extent that's outlined in the CPT codes? And the final piece would be the third bucket, is there actual monitoring happening of that data, and therefore a patient's care is impacted by a provider looking at that data and doing something. So those are kind of the 3 different areas. What Medicare did on January 1st of 26 is actually made the thresholds for how much data had to go back and forth and how much time needed to be spent by a clinician doing the monitoring. It actually made it slightly easier for practices to build for RTM codes by dropping those thresholds down. So one would look at that and read the tea leaves and say, okay, 2022, Medicare introduces new CPT codes to allow this. 26, they double down and actually make it easier for us to do this. And I think it really shows a willingness on CMS's behalf to expand care outside of the 4 walls of a clinic and be willing to pay for the care that happens in between the visits. So what we always talk about is that we are built for the 166 hours of the week, when a therapist is not. With 168 hours in the week, you're at therapy twice a week for an hour at a time. What happens during the rest of that time? Well, the bulk of the recovery or lack thereof is what actually typically happens during that time. How can we be doing something both synchronously and asynchronously with patients in order to not have setbacks in between visits? And hopefully we're actually even improving during those visits by utilization of home exercise programs, tackling any problems or questions that come up with patients. So I would have answered this question, Alex, and said that 3 weeks ago, and said that CMS has very strongly indicated that they believe this to be good care. It should be easier for providers to be reimbursed for the care that it is, based upon everything they did in 2022 and then in 2026. The proposed rule that came out 2 weeks ago is putting a few roadblocks in the way of that, while also frankly supporting what good RTM should look like. So I think it's a little bit of a mixed bag in there that I'm sure we're going to get into, but I'll pause there. Dana, you especially as the policy guru relative to me, I don't know if anything I missed there you wanted to add.
Just to some color on the why, the pivot now. It's not a coincidence that the access model is out, and RTM and RPM are codes in the access CMMI model that are considered substitute codes for access model participants. So if I'm an access model participant and I'm providing an AI/tech solution for patient engagement, if a patient is also has an initiating visit for RTM and the MSK track, that is going to count against the access organization. So without getting too weedy, the concept of RTM is getting sucked up into the larger issue of chronic care management.
You said there, I'm fully on board with as far as like intent and how things are written and some of the correlations. But I also think this is a baby in bathwater situation that we're dealing with here. Is that the reason the proposed rule that just came out is equating fraud, waste, and abuse that is not clinically, but is documented by investigations by the Office of the Inspector General in RPM that is rampant. And it is assuming that those things are or will happen in the world of remote therapeutic monitoring without the evidence to support. And so as an example, I just mentioned those 3 buckets of codes before, that we have the provision of the device, we have the data transmission, and then we have the actual monitoring side of things. In those OIG investigations, 43% of patients didn't receive all 3 of those things. On top of that, 10% of those patients, there might have been 12%, but a significant number of those patients weren't ever seen by a physician, and the RPM wasn't part of an actual course of care. So some of what CMS is attempting to regulate through this rule, that RTM and RPM be connected to a course of care, that it be initiated by an evaluating provider. I'm all on board with that. Like, that should be happening. I think I've never seen an episode of RTM occurring in the thousands upon thousands of patients that we're dealing with every day where that's not the case. So I understand what you're saying, and I don't disagree. And it is around CMMI and some of the things they're doing with access and where we're moving for chronic condition management. But I think there's a whole nother part of this too, which is that there's an assumptive part of this that assumes that if this is happening in RPM with direct-to-consumer solicitation of Medicare beneficiaries, enrolling them in RPM, not having a physician involved in any way, shape, or form, must be happening or will happen in RTM, and I think it's a false narrative.
Every policy that's put out, there's a goal in mind, there's a reason. It doesn't mean that the reasoning is always correct, and that's why we have the notice and comment rulemaking process. Hopefully, we're sharing this real specific feedback back so that what is not well-founded and where we have good arguments is not finalized. And so I think it's a really important point to bring up, that we're trying to sweep RTM into RPM, but also that there's a difference between completely tech-enabled solutions that have no human in the loop and solutions that enable therapists, clinicians, whatever it may be, to do that, dual type of care where they can provide in person, they can provide hybrid, they can provide RTM. And that's really what we have missing right now. The way practices are set up, it isn't so easy to do all 3 together. And that's just a reality of the way practices are structured. So it doesn't mean that, that this is the right solution. It just means that these things are things they're trying to figure out. And this is the proposal they think is going to be a good solution. And why we have a comment process to begin with.
Agreed. All right. So why do you think, and this is more of a overarching narrative, RTM codes came on the market in 2022. It's 2026. And it's still, like, if you look at the RTM system participation, you would expect close to 100% participation on the system level. And that's not anywhere near that, right? Like, so on a traditional legacy provider, I think it's 23, 33%. Like, it's low compared to what it could be. If the codes came on the market 4 years ago, if the codes generally are pro-social in terms of they extend the course of care, they extend continuity of care, they promote active, positive use of technology to improve clinical outcomes, why has our community not embraced these systems more readily? And what is the barrier to that acceptance? Well, like, what's stepping in the way?
Yeah, I think that it's an excellent question, and it actually feeds back into one part of the proposed rule that we didn't tackle yet, which is who's providing the monitoring care. So one of the provisions in the proposed rule is that the provider who is doing the monitoring of the patient must be a direct employee of the practice where the patient is receiving care. And this is a tremendous barrier to, if enacted, to patients getting RTM care and patients getting better and patients achieving the positive clinical results that are documented in the research associated with a combined approach of RTM and in-person care. And the reason I bring that up is actually links back to where we started. One of the biggest macro trends we're dealing with is the fact that we don't have enough therapists. And so I'll just give two concrete examples from clients of mine. I have someone who has 10 clinics and 50 locations in a very rural area. With this recent cycle of therapists graduating, he was hoping to fill 10 spots with new grads. He was able to hire 4. So he's still got 6 more openings. And he has told me verbatim, he's like, Ben, I can't put RTM services on my therapist who are already over capacity. I already have wait lists. I do not have openings. I'm going to ask them to do one more thing. That's going to create more burnout and more attrition. And the problem I'm trying to solve actually is going to get worse because I'm trying to employ this, but I don't have the bodies to do it. And so then I just extrapolate that into, okay, well, what does that mean at a population health level? That means that they are the only private practice in every county that they serve. That means that any patient that is seeking physical therapy care is essentially ineligible for remote therapeutic monitoring services because of this lack of staffing flexibility that this gentleman has because of, frankly, his zip code. And let's not underestimate the fact that we're talking about rural geographies where the socioeconomic determinants of health are already a headwind he's dealing with all day, every day.
That rural argument is a really important one. We have the Rural Health Transformation Program putting $50 billion into rural areas. And a lot of it is, trying to address creative ways to improve access to care of all kinds, and remote monitoring, e-consults, you name it, telehealth. These are the things that, if the infrastructure is built, will provide that, access that patients need. And besides the fact, the point that you make about being able to hire enough, the value of a service like RTM in rural communities is even probably more important when you may have trouble in rural communities seeing patients at an ideal frequency. It can become difficult for them to keep appointments, and that monitoring is extra important. I would say that in commenting, those are the kinds of examples that can be linked directly to the risk of higher cost non-therapy but interventional care that can come from not being able to engage patients effectively. And that RTM is a solution for that. We have areas of the country that desperately need this kind of service. Something like the Peterson Health Tech Institute's report that said, it's like the Limber model is really effective, but it didn't decrease costs of the episode. It was really good care, but it didn't necessarily decrease costs. Do you think, and I literally have no insight into this, I haven't seen it in action, so I really want to hear your thoughts, probably varies based on geography. But do you think there's an opportunity to be doing perhaps even more RTM and less in person, or modulating that in person to allow more of the RTM or hybrid visits, even maybe for a longer period of time, to help prevent downstream utilization outside of a typical episode, and maybe more intermittent care that I would hypothesize demonstrate that RTM can add more value without increasing costs?
I'm glad that you brought it up because it's out there and it's easy to access, and Peterson does amazing work and is highly respected for very good reasons. What I would say, I think that the core of my response to that is there is not great longitudinal data on patients who receive physical therapy and what downstream costs truly are or not. And if we are looking at RTM as to be the savior of PT costs, and if that's Medicare's goal, is this is going to drive down the cost of PT, introducing it in a way that as Alex brought up when we started this segment, that feels to some practices as a lifeline in a declining reimbursement market is counterintuitive. And so my response to that is that the reason that physical therapy is going to have growth that outstrips the rest of the market of healthcare going forward is because of its efficacy in addressing musculoskeletal specifically conditions early and in a cost-effective manner. getting more people into that care is going to cost more money because more people are going to be getting physical therapy. The problem is because we all operate in silos and because we don't have longitudinal data, we don't follow people after the episode is done. We're not tied back to these advanced primary care groups and have the data on overall spend for years at a time, that it becomes really challenging to have those. And so what we end up doing as a profession is saying, this is good care. This is getting better outcomes. Patients are getting better. That should lead to less downstream costs because here are all these studies around cost that showed that PT is effective on cost. And we're asking people to make a leap of faith from a higher PT bill to lower costs in the healthcare system. And that's dangerous, and it's where we lose regulators.
Right. It's how you frame it. I think that the framing of the effect, and in general, I think the framing of cost reduction is a fallacy. Because cost is a poorly defined term, and especially primary cost can be calculated, but we're not even going into all the externalities. Do you think RTM systems, or I would even zoom out and just say hybrid care in general, is something that can be successfully operationalized on a network level and the general consumer of musculoskeletal services? So pretty much anyone who's consuming physical therapy will embrace that model when there is a more of a cultural social stigma that the only care that is worth its weight essentially is when you put your hands on me, when you touch me. So anything outside of your warm body being next to my warm body in the same brick and mortar site is substantiated, and everything else is just fluff. So to get away even from RTM systems and to discuss the true need for digitization and hybrid care delivery, do we have a more of a cultural constraint that what we approximate as valuable service has to be delivered by a human with warm hands?
I think it's a great question, Alex, and it's one that I could spend the next 3 hours talking to you about because I have pretty strong opinions about this one. I'm gonna start with a soapbox for a second. There are many of my very close friends in this industry that will swear to you that the only model of therapy that makes sense on a go-forward basis is one-on-one care for 40 minutes at a time. Mm-hmm. And I've always, when I'm feeling a little ornery, I will always ask for show me the proof. And it doesn't exist is the short answer. And I also will then say, how did you arrive at 40 minutes and not 36 or 30 or 60 or 45? And I know the answer, which is that's actually the round number that allows you to waste the fewest number of minutes in a CPT code 8-minute rule environment. It allows you to get to that third code. And so therefore my response is, hold on. You're providing this care and you're saying it's better than everything else, but the reason you're providing this care is that it allows you to get to that third CPT code and bill differently. So I just want to give that as a caveat that this is my own personal bend that I come to this kind of conversation with because the whole thing doesn't make a lot of sense to me. I feel like I'm beating a dead horse here, and the other way is that I think that we have a tremendous opportunity in front of us as a profession over the next 10 years because we're no longer fighting for referrals. We're no longer we're not trying to figure out where is the next patient coming from? How am I going to fill my schedule? I need to go do A, B, and C in order to make sure that my therapists are productive. We are now solving one of two, if not both questions, which is we are going to be busy. How do we want to be busy? Right. Mm. So those are going to be full and we are going to be at quote unquote at capacity, whatever that is for the next 15 years. So, and we are not going to meet the demands of the market, and we are going to miss the boat as a profession if we continue to treat in this one-on-one model only, because by doing that, it's a capacity constrained model where the therapist supply is going to dictate the consumption of the market. And we're going to leave tens of thousands of patients out on the street going to find somebody else to go address their pain, which isn't good for them. It's not good for the system, and it's not good for us as a profession. So, Alex, I don't know if this necessarily answers the entire question, but it is a paradigm shift that has to happen, and some really difficult conversations need to happen, therapist by therapist and practice by practice, that says even if you think 40 minutes one-on-one is the only way to get someone better, I'm telling you, you are responsible for the conservative MSK care of the community that you serve. how do you see more of those people and impact more of those humans' lives?
How can we provide more access by leveraging digital front doors and RTM and hybrid visits on top of sometimes less visit frequency? Because we all know we still have an entrenched belief that, number one, the most profitable clinics, which I don't believe are true, and the quote best care is 2 to 3 times a week times 6, 8, 12, you name it, weeks. When the evidence doesn't suggest that that's true, post-op, there's lots of cases where patients do need a lot of volume, but where as much as we talk about the 40-minute issue, there's also the visit frequency and volume issue. And I know why we got there. I am criticizing my own profession with a total recognition and living through it of why we are there. But how much can we solve potentially for the access problem that already has wait lists if we are to reimagine what it means to provide good care and what access needs to look like? How are we where are e-consults even in here? I know one therapist who was on last week on our podcast, Brian Westlake. We're not doing a lot of e-consults even, right? That's so nascent. But where can we be leveraging all of these different solutions and thinking differently about the role of a therapist, not just in an episode and a frequency, but also how do we make sure they look at us as a part of their care team? As their
so I think that's
therapist.
a great call out, and I do want to second what you just said, which is that we on this call to help to create where we are too, in some way, shape, or form. Like, we've all been a part of this industry for a long time. We all lived it and benefited from it and had strong opinions about it at one point that may or may not have evolved. We lived in a different world in 2000 when we couldn't fill schedules and there was no direct access and people didn't know the difference between us and physical trainers and things like that. Like, we are no longer there. And so that's where I think that we need to stop. I own a clinic. That clinic is going to go hit its capacity, quote unquote, of visits in the next year, one way or the other. We're going to be full. We're going to have more patients than we know what to do with. Our rate limiter will continue to be the number of therapists that we have in the building and the number of hours that they're working, nothing else. That is the rate limiter. And so if I take that and I understand that reality, what I then care about shouldn't be throughput. It shouldn't be productivity. It shouldn't be visits. What I should care about is the number of lives that I've impacted.
100%.
How many new patients did I get through the door? How do we then segment the course of care based upon the people that can, will, or should be in the clinic 2 to 3 times a week versus those that don't need to be? I have a perfect example. There's a patient that I was talking to one of our clients about who has, essentially fired 3 PTs because
love those.
We all have those. We all have those stories, and we all only talk about them because they ended up with us and it went well. We never talk about the ones that actually fired us. But in the reason, like the ability to meet this person where they were and to provide some level of care while she travels for 2 to 3 weeks at a time for her job, and still be able to provide a level of care through some. I'm not even going to talk about hybrid RTM because I think hybrid care can look a lot of different ways, and they all have a value. That was the thing, because the model didn't make sense for this person. You mentioned the rural thing before, Dana. Driving an hour and a half to a clinic twice a week for an hour of care when you have ridiculous low back pain that is aggravated by driving might not be the best choice of how to meet a patient where they're at. And so I think that if we realize that a capacity constraint is no longer patients and or visits, and it is, there are more patients than we know what to do with. I think it then allows us to think about what are the different pathways that a patient could be walking down in my clinic based upon diagnosis, acuity, socioeconomic status, comorbidities, whatever the other things are. But we can reimagine what good looks like if the number one metric we're measuring is not how many visits we did. The number one metrics we're measuring is how many humans' lives did we impact and make better.
And I would actually not challenge what you said, because I think what you said is absolutely correct. I would challenge, rather than a capacity constraint, it's urgency constraint. Because the heuristic here is that we are providing care indiscriminate of need. We're providing care based on availability of resource. So when a resource is available, we oversupply these resources with patients that are willing to come without discriminating the need based on clinical urgency, based on stratification of actual prognostic effects that apply to that specific encounter. So biggest predictor of somebody receiving physical therapy is if there's a physical therapy clinic within a 5-mile radius from their house, they're going to be, they would have consumed that service within the last 12 months. That's just a geography at play, right? And then we have this rural effect. So just to reference what you guys were saying, you're absolutely right. And rural health sucks in this country, and not just in physical therapy. There's like a 25% attrition of orthopedic surgical services in rural health in the last 15 years. So orthopedic surgeons are getting the hell out of rural health. Like they're going to the cities. So you can't even get surgery in rural health. You have to travel 100 miles to get an orthopedic surgeon to look at you. But that's not basic supply and demand ratio. It's the fact that we're oversupplying low value services because we don't discriminate whether you need X amount of visits. We provide care based on availability of a patient who's willing to pay, who's willing to come in. And there is a nonlinear impact of clinical care in physical therapy world between visit 1 and visit 4, right? 70% of clinical efficacy occurs in the first 4 visits. 95% of clinical efficacy occurs in the first 8 visits. That's current empirical evidence, and I'll cite the sources. What happens after that? Why is the average length of stay? Why is the SFQ, script frequency quotient, like 14.8 visits nationally? Why are we providing so much care? Does that mean that we have so much urgency, or is it just a willingness to come, willingness to pay, right? As an economic matrix, willingness to pay is something you can measure. That the base individual satisfaction with physical therapy care is dependent on your willingness to pay. If you're willing to pay for services, I'm going to be really happy with you. And if I'm not willing to pay for services, I'm going to be dissatisfied regardless of the patient-reported outcome measure. Like, so willingness to pay is one of the matrices. The other one is that we have 275,000 physical therapists. We are graduating a shit ton of physical therapy assistants. We have not operationalized the model where you have physical therapists that operates on their best available resource, which is stratifying risk, triaging, creating plan of care, identifying barriers, identifying red flags. Then physical therapy assistant creates a treatment plan course through the course of care, supervises the treatment plan, identifies any urgencies or escalations, and then you have support personnel or athletic trainers that are able to then continue that. That's tiered model, that's step tiered model of care. But that's not what's happening, right? What happens is that if you have a therapist that onboards a new eval, a new therapist, if you have a private practice owner that onboards a new therapist, and that new therapist needs to fill his schedule or her schedule, that schedule is going to get filled regardless of whether somebody needs to come twice a week or 3 times a week. And your ability to create that plan of care through the volume of care is not science-based. We've never been science-based in terms of the volume of care, predicting the total volume of skilled in-person services dependent on clinical urgency. We don't do that. What we do is we deliver care based on availability of resources. So potentially that's the working hard or working smart, where we're kind of like perpetuating the same cycle that if we pump out another 50,000 physical therapists in the next 3 years, what's going to happen is that we're going to still over-provide care to someone who may not need to be in person. And at the same time, someone who does have this clinical urgency, someone who has acute radiculopathy, who actually needs to be seen and needs that, like it has multiple comorbidities, has a lot of physiological barriers to recovery, that needs in-person care, can't get in because somebody with low-grade ankle sprain is on his visit 16 doing single leg stance with a PT tech, right? So that is my bandwagon. So what do you guys think?
Well,
I don't know. I think we're not on the line. And I think that the trick is going to be, how do we put one foot in front of the other, Alex? Because what we're not going to be able to do as a profession is to get from where we are to that perfect state without a lot of steps in between. And this is where I think that understanding why people have and have not adopted hybrid care approaches within their business is really important to unpack, because it's not because people don't want to. It's because they either don't see the value, or they don't feel like they have the resources, or they're worried about change management, or any other host of things that are out there. And when there are headwinds and perceived barriers to change, people default to their current behaviors. And their current behaviors are the same care that was provided in the 90s and 2000s when patients were scarce and therapists were plenty. And that's, I think, where we need to get back to, is understanding, look, everybody that came to this profession because they wanted to help somebody get from where they are to where they wanted to be in terms of functional abilities. And that's true whether you work in a senior living setting, pediatric setting, traditional outpatient ortho, whatever. If we are able to bring someone along on the journey with us and show them a different way that is backed by evidence and research, that creates not more work for someone who's already just barely hanging on with the amount of administrative burden that he or she has to deal with today, I think we stand a chance. If we're not able to make that pathway from where we are to where we need to be one that has little friction, I think it's going to be really challenging. And I think that friction is what results in people doing the exact same thing they've always done.
Couldn't agree more. I will say, as I'm listening to Alex, talk about the willingness to pay issue and how we end up scheduling how we do, it's not that different for physicians, right? I mean, the fact that you could have an urgent issue and you can't see your cardiologist for 3 months and you end up in urgent care where they're not suited to see you is exactly like it goes to the whole concept of value-based care. And I find a way somehow at every episode to tie things back. But even primary care, so specialist physicians don't have the same incentive we do to think differently. If you're making $500,000 a year every year versus you're making $100,000 as a PT, well, totally understand you don't have the incentive to change the way you do things, right? Makes a lot of sense. But where primary care and behavioral health that's embedded in primary care have shown us a different way is when you are in a model that incentivizes upstream care, being able to access a physician or a PP or behavioral health provider the day you need them, right? And that is prioritized, and relationships with your patients and finding any way possible to make sure they can communicate with you so that you don't end up in an ER. Where that's prioritized, the whole script is flipped around. And I guess this is why, for all of the pushback therapists give, I get some that get it. They can imagine the future. But sometimes the pushback, I feel like, is a lack of awareness of the future is possible. Doesn't mean that the steps to get there don't take years. They do. I'm not trying to simplify this. But just to reiterate, the whole thing about how we schedule and why we do, and filling out schedules for convenience, for who's willing to come, for who's an easy patient, for who we don't want to discharge, all those things, it's not that different from everyone else in the medical community who schedules out for months. And that has nothing to do with urgency in some cases. It's just, I check you, you come every 3 months because you have heart failure and I see you every 3 months. Doesn't mean that you're the most urgent. And I'm not seeing someone who could have more downstream costs because I can't get them in. It's the same kind of problem. It's just, for us, similar to behavioral health and primary care, there's a lot of upside financially if we could figure out how to practice differently, even outside of accountable care. Evals pay a lot more. And if we could be doing more evals and seeing more patients, to your point, how can we make it possible to help more of the community to see us quickly and efficiently without a lot of friction? We can solve some of this, a certain percentage, even take pre-steps to value-based care. If we can begin to move towards that model, optimizing the work of PTAs, improving access to evals. I mean, those are the kind of the pre-value-based steps that we can consider really value-based care for our profession, I think.
Well, Dan, I think it's well said, because I was thinking about you as I was getting ready for this conversation, and obviously knowing your role in value-based care and some of the conversations you guys have had on this podcast. We have an opportunity in front of us because of the challenges that we're facing to get closer to a value-based care model in physical therapy and to prep for all these things because of the realities of the environment that we're practicing in. Right. And so Alex, I agree with everything you said in terms of willingness to pay and things like that. But at the end of the day, I'll go back to what Dana said, because it's the math I do as a former practice owner in my head. If my schedule is quote unquote full and my throughput is fixed, skewing towards evaluations is better for the financial stability of my practice. Like, that's just math. And you know what it also might be? Better care, especially if we can be treating those patients, I don't even want to say treating, engaging with those patients outside the four walls of our clinic being okay only seeing that ankle sprain for 3 visits and setting them free and monitoring them remotely for 2 weeks before the next visit, that's a very different care model that's allowed today
right now
without financial harm to your private practice today. Absolutely. Because we have so many patients and not enough therapists. So now is the time to be thinking about doing these different care models and to be taking those baby steps, because it's not going to financially harm you. If anything, it's actually probably going to make you more financially solvent as a business, be able to help you reinvest in your staff and pay them greater than 3% increases every year and things like that, because you're changing the overall paradigm of what care inside of your physical therapy clinic looks like while preparing for what 10 years from now might actually look like.
Building a system, and you are building a system of operation that supplements the system that you have existing. You are creating a model of care that will future-proof you for the next decade or two, because this model where you are providing services based on need, as well as being able to categorize the right discipline to provide the service, as well as using digital resources to supervise care outside of your clinic walls. That is the system that needs to exist for capital reasons, for commercial reasons, for economic reasons. It's the system that needs to be, but who's ready, right? Who's willing to do it? Like it's it's an age-old phenomena that the decision makers, the ones that create these systems, are the ones that least understand these systems, because they're indoctrinated that the default mode of operation, that reduction to the default, that I am used to seeing patients in my clinic, I'm just going to maximize the volume. And part of it is, I think, a human heuristic that it's comfortable seeing patients for a while. You establish relationships. We're social beings. We like seeing people. So that retention, indefinite internal retention of the individuals, hits to the bottom of our social being, that we want to be with these people because it's fun. It's nice. It is energy economic. I don't expend energy when I'm seeing the same patient multiple times, because I don't have to use my intellectual equity. I can just cruise along and have a nice conversation for the next 40 minutes. It's a numerosity effect. Like we succumb to numbers that are round and that are big because we like these numbers. There's a lot of interesting effects. It's the same as a dose response. I've asked this systematically over years. What is the optimal dose for specific diagnosis? And is there a consensus in the physical therapy world that, like, you need 6.7 visits for an acute lumbar radiculopathy without myotomal involvement, right? Like, is that the best number? No, there's nothing to guide you. You have CPGs that are loosely guiding you, but that's all it's supposed to be. So I guess you guys both are 100% consistent that, like, these are models that are out there, they're available. You 2026, you can start to reshape your model, but nothing changes when nothing changes. And the agent of change has to be someone sitting in a clinic and saying, like, on Monday, I'm going to start to figure out, I'm going to take out my Excel spreadsheet and we're going to start to figure out resource allocation a little bit differently. That would be great, right? Like, if one of 14 people that are actually listening to these episodes actually does that.
Well, I would challenge anybody who's listening to this today to go look at their wait list on Monday morning, because there are people not getting care because of rationing physical therapy right now. And people get really fired up when I say that, but I lived over in London. I worked in NHS for a little bit, and they obviously are the kings of rationing care because they have to. We as physical therapists ration care every single day. We typically ration it. We typically ration it based upon when you pick up the phone and call us. And if you call us sooner, I'm going to get you in sooner, as opposed to whether you need to be seen sooner or not, right? I mean, there's some gradations there, but it's happening. There's no rhyme or reason as to why someone's on your wait list, and whereas Ben got seen today and Alex has got to wait for 2 weeks. It's most likely because Alex picked up the phone the day before someone went on vacation, whereas Ben called 3 days earlier than that and you had capacity. And so I think that if you as a leader in the physical therapy industry are looking at a wait list and you start thinking about that as opportunity lost for us as a profession and opportunity lost for us to have impact upon the health of these individuals, you might think a little bit differently about how to create capacity in your schedule. And creating capacity in your schedule doesn't necessarily mean you have to go triple book everybody and see 90 patients a week. It might be, you know what? Do I really need to see this person a third visit this week? Like, they're doing great. They're on this trajectory to the happy path. It's that all the data and all the functional outcome measures that we do suggest that this person is on the way there. Maybe I don't need to see him Friday and I can get in Dana who's just sitting on the street right now. And I think that just that mindset is different. It's not like, hey, look at this, we got a wait list. Like, you should not be excited about that.
No. What if instead of seeing that person for a third visit, you had 15-minute touch point on a telehealth visit? To your point about our profession, we assume so incorrectly that physicians, especially primary care physicians, know what we're capable of and how much more we can be a direct support line to see patients, that would otherwise be seen by them, who they can't manage, who are then going through this messy referral system, taking weeks to get in, sometimes never showing up. I feel we are a doctoring profession. We should be providing the best possible access to care, not just care. All physicians should be doing the same if they can, optimizing for access. But for us, we have so much upside to changing. And point taken, and totally agree. It's monumental to think about what does value-based care mean for therapy, but we haven't taken those pre-steps, and we have the ability to do it with the tools that we have right now, exactly as you described, to provide higher value care, more access. And that's when the data starts to show earlier access to PT shows a lower downstream spend because they didn't end up getting other things they didn't need. That's the bottom line. And ACOs have all that data. They just have to decide how to stratify, when and if to stratify it. We have the lead model with the embedded episodes. The first episodes are for therapists. I haven't heard a single therapist talk about the CAR model, the CMS administered risk arrangement model. We are the target of the very first one, falls episodes of care. We should be on that like white on rice. It's an invitation.
Guys, this is great. We should do this again sometimes when we are in person over beer or other beverage of choice.
Well, if I were to get back into the physical therapy services game, so I actually decided to go open up clinics again and start actually providing care again, I would be doing it where all patients are receiving some level of hybrid care. The number one KPI that we talk about every single week, month, quarter as an organization would be around lives impacted. It would not be around throughput and visits and CPT codes and things like that. Those are all still important to some degree, but that wouldn't be the headliner. And I would be looking to find ways to create care paths inside of the four walls of that clinic and beyond through hybrid approaches that allowed our impact to be 2, 3, 5, 10x what it would be in a one-on-one model. That would be my mission. And I think that we have a lot of the tools necessary in order to do that. I think that it is a mind shift or a mindset shift that we need to go through in order to get there. And I actually feel strongly that there are young, new entrepreneurial therapists that are thinking similarly to this and not accepting the status quo of this is what good looks like because someone told me it's good looks like, or because a CPT code tells me this is how I need to treat. And I'm optimistic because of that. But I think it's going to actually have to happen one practice at a time. So I think that if I were to get back in the game in open clinics again, it would be around a race to see how many members of the community that I served could we impact. Not can I be busy and can I be profitable? Because I think that if you start with the first one, that gives you your purpose, and the rest comes from there.
Free consulting for anybody who made it through.
That's okay. Thank you, guys. Dan, thank you again for your time. I think it's terrific for you to spend some time with us, but even more wonderful everything that you're doing for our community and our discipline. So thank you for that.
No, I appreciate you guys having me. Like I said, I think that you're two of the really important voices in the industry, and that you don't ever feel as if you're in the echo chamber. And without necessarily being contrarian, it does feel like you are thinking about things bigger and more in the future and more attached to the rest of healthcare, as opposed to how can we edit around the fringes and make whatever we're doing a a half of a percent better next year. So appreciate what you guys are doing and happy to spend an hour with you. So thank you.